Hello, dear intensivists. This is Dr. Abdurrahman Nagi, and I will talk about the lung auscultation. Lung auscultation is an important part of examination in ICU or in ER when you assess a patient for admission to ICU. Also, it's an important part of rounding in ICU with patients either on a ventilator or an IV or just a routine examination. I'll cover the most important sounds of lung, either for physiological sounds and pathological sounds, and how we will simulate those sounds. We'll show the patterns of breathing. We have more than those three sounds in physiologically breathed sounds, but we will focus on those three in orders. We will first start with bronchial breathing, then bronchovesicular breathing, and vesicular breathing. So the bronchial breathing is loud and high-pitched. Part of inspiration and all of expiration are audible with a distinct pause between them and can be heard over the sternum. Listen here. Now we will go to the bronchovesicular breathing, which is intermediate intensity and pitch. Inspiration and expiration are approximately equal in duration. So where we can hear it anteriorly over the first and second intercostal spaces and over intermediate airways. Then we have the vesicular breathing, which is soft, low-pitched. Inspiration is longer and louder than expiration, with expiration heard only partly. So we can hear it on the most peripheral lung fields, over the terminal airways and alveoli. Then we have the pathological breath sounds. Pathological breath sounds are also called adventitious or added sound or additional sounds. We will start with fine crackles or crepitations or rails, then the coarse crackles or crepitations, then wheezes, then rhonchi, stridor, pleural friction rub, then the muffled or absent breath sounds. Let's start with fine crackles or fine crepitations, which is discontinuous, intermittent, soft, and high-pitched, usually heard in mid to late inspiration. So it's produced by sudden opening of small airways, classically described as Velcro-like, may occur with pulmonary fibrosis, asbestosis, sarcoidosis, and pneumonia. Coarse crepitations, which is discontinuous, louder, and lower pitched, often occur early in inspiration and continue through expiration with a popping quality. So it's produced by air passing through intermittently opening and closing airways, associated with COPD, pulmonary edema, pneumonia, and collapsed small airways or alveoli. Then the wheezes, which is musical, prolonged, and usually high-pitched, most commonly expiratory, usually reflects distal airway obstruction. Common causes include asthma, COPD, bronchitis, anaphylaxis, pulmonary edema, foreign body aspiration, and structural airway disease. Bronchi, low-pitched and coarse, snoring-like sounds, often caused by airway secretions and may clear with coughing, commonly described in bronchitis and bronchiectasis. Stridor, harsh, high-pitched sound, best heard over the trachea, suggests airway obstruction. Inspiratory one indicates extrathoracic obstruction. The expiratory one suggests intrathoracic obstruction. And the biphasic one suggests fixed glottic or subglottic obstruction. The pleural friction rub, scratchy, high frequency or squeaking sound during respiration caused by inflamed pleural surfaces rubbing together, occurs with pleuritis, pneumonia, pulmonary embolism, and other pleural inflammation. Muffled or absent breath sounds, markedly reduced or inaudible airflow sounds, suggest air or fluid between lung and chest wall, such as pneumothorax or pleural effusion. Bilateral reduction may occur with severe bronchospasm or airway obstruction. Next, we have the patterns of breathing. we have the normal breathing pattern, and the cosmal breathing we can see in metabolic acidosis, DKA, and uremia. The Kain-Stokes appearance, which is maybe it shows a similarity with the Biot's appearance, but we will show the differences in sounds. And we have the apnostic and ataxic types of breathing.